Thank you guys so much for listening to this episode. I have an outstanding guest for you. His name is Alex Effer. He is a Canadian clinical exercise physiologist. He graduated from the University of Toronto with a BKin, as he calls it, which is a Bachelor of Kinesiology. Then he did his post-grad work in Niagara. Unbelievable approach to rehab. Really talking functional movement patterns, ways to understand biomechanics, how important that is for what we do as sports physical therapists. Taking a joints approach to biomechanics, understanding what joints should do, then layering on top the muscles. It's really a flip in the script of the way we standardly assess and diagnose and progress patients. Not so much about muscles, far more so about joint biomechanics. So as always, I learned a ton from Alex today. He was outstanding. His podcast is awesome. Short snippets on the way he approaches biomechanics. It's called the Resilient Rehab Podcast. Please look that up because that taught me a ton. As always, let me know what you love. Let me know what you hated and who my next guest should be. Please share this podcast so everyone can learn, understand the genius of Alex Effer. Without further ado, here's my conversation. Thanks, guys. True Sports family, welcome back to the True Sports Physical Therapy Podcast. My name is Yoni Rosenblatt. I got Alex Effer with us. Alex is a biomechanist guru, a physio, as you call him up in Canada, I believe.
Yeah, physio.
Okay.
Yeah, so technically physiologist, but yes.
Physio. We'll call it physio.
Yeah.
And welcome to the pod. Alex, thanks for making time. Thanks for being here.
Thank you so much for having me. It's an honor to be on. I always enjoy talking with like-minded people about these kind of things. I nerd out all the time on biomechanics, so this is great. Thank you so much.
Based upon the conversation we just had before we started recording, it sounds like you nerd out on everything from World War II to biomechanics. So happy to pick your brain. Let's start overarchingly. You make a great point with all of your podcasts, everything you're putting out around the import of putting focus on muscle or bones and joints rather than muscles. Just give me some idea of why you think that is so important as approach for us physios.
Well, I think a lot of times people focus on this muscle-centric approach, and it's because it's what we've been taught. And I think a lot of, if you want to talk about strength training, for example, a lot of that comes from bodybuilding, right? A lot of the principles come from bodybuilding, powerlifting, even from a treatment standpoint. They call it the musculoskeletal system or musculoskeletal system. So they start with muscle in the name, and words are powerful, and people start to focus on muscles. And also muscles you can see. Obviously, bones are underneath, joints are underneath. And so people like to focus on muscles. Like the hip flexor is tight. That's why you have an anterior pelvic tilt. Your calves are tight, so you got to stretch them out. You have limited ankle mobility because you have tight calves. When in reality, there are so many other factors at play that will actually impact the muscles. The muscles are reactive. The nervous system is going to kick on a certain muscle as a reactionary defense mechanism or based on where your center of mass is. And so the way that I look at it is, let's just say you have a right hip hike. Okay, so people will say, well, that's your QL, that's tight. Other muscles around the hip that are tight, so we got to release that. But that doesn't really change things. You get people on the table, maybe some of their table measurements improve. They walk out, they come back, same situation. And the reason for it, the way that I look at hip hike, for example, is it is more of a center of mass issue than it is an actual muscle issue. And so how I explain it is, pretend I'm standing beside you on the left side and I push you towards the right. Well, in order to push back against me, now I'm Canadian, so hockey is kind of the first thing that comes to mind, but let's pretend somebody's trying to body check you. You have to lean into them. So that right side needs to be able to push, and that is internal rotation. That is hip extension. That is propulsion to push off in order to resist that push. If I can't do that, then what's going to happen is I'm going to start to fall on the outside of my right foot. So now my right foot's going to supinate. Everything's going to externally rotate. But if I fall outside of my base support, then that's where I'm unable to catch myself. So I'm going to fall over. So how am I going to push myself back to the center? I'm going to roll my shoulder forward. I'm going to push my head forward towards the left, which is sometimes when you see people from the back, you see this forward head, but also a slight rotation. I see a rib flare. I'll see a side bend going through the rib cage. I'll see a valgus knee, a collapsed foot, right? So you see all these different types of presentation. So first level of thinking is there's center of mass, there's basis support, right? And then you want to go in deeper inside. Well, you breathe 23,000 times a day, right? The pressure that changes inside your pelvis, inside your rib cage, well, that's going to alter tension in the muscles. There's a how do you call it? There's a model. It's called Loom's hyperventilation model. And his model basically starts with breathing. So you start to hyperventilate. Then it starts to impact the nervous system. Nervous system gets stressed. You become fight or flight. You get anxious. You're more fearful. Your pain receptors now start to kick on a bit. The pain centers in your brain start to kick on a little bit, which is in similar areas as your fear and anxiety. Then it goes into changes your pH. Then it goes into changing your posture. Then it goes into muscle. So even in this model, which was written in the 70s, focuses on muscles later. So we look at center of mass. We look at the pressures, so the stuff happening inside out. So when I breathe in, things externally rotate. Certain areas of my rib cage have to expand. When I exhale, I now am increasing pressure within my pelvis, decreasing pressure inside of my rib cage, because now the muscles on the outside have to contract to get air out. So I then have that. I've got my basis support. I then have all of this is going to impact the position of the joint. So now if my center of mass starts to shift forward because I'm lifting heavy, so I need to produce a lot of force all the time. I'm in certain seated positions. I'm looking at my phone, which brings my center of mass forward, right? All these things are pushing me towards my toes. And then we say, oh, that person's a butt clencher. Okay, let's release the glutes. It's like, well, look at everything above the chain. That glute being pushed is the right and left side pushing against each other to try to come back to the middle, right? So if I shove you towards the right, you're then going to side bend to go back towards the left. Well, how are you going to catch yourself now over to that left side? Because you don't have internal rotation because you pushed over to the right already. Mm-hmm. Well, then you're going to do something else with the left shoulder. Maybe you're going to flare your rib. Maybe you're going to hike your shoulder up, right? So you're going to do all these things, and then the muscles are going to react. So I know that was like a long-winded answer, but when you start to look at it, and I've had so much more success with focusing on, let me get this tibia to internally rotate. Let me try to get the PSIS in contact with the ground when they're on their back, so I can get a pelvis turning towards that side, which is then going to inherently open up the entire back part of the hip, right? I mean, we give people SI joint belt, right? Why do people give that? They'll think, oh, it's to stabilize the joint. If you actually look at what it's going to do to the pelvis, it's actually going to laterally compress the pelvis, which is then going to lift up the pelvic floor, increase pressure in the pelvis. And what is that? That is internal rotation. So even our things that we give people, orthotics, these are not to influence muscle. These are influenced to the joint position so that the muscles can then relax.
And work more efficiently. Okay, so I was going to ask later on in the pod why you think like what you just laid out is not covered so well in our graduate school education. But having listened to you explain it, that sounds so goddamn complex. Like there's
Yeah.
so many systems that you just talked about that I really don't have an awesome understanding of how to manipulate. For instance, like I know there's PRI and ways to manipulate your breath and understand like chest expansion and stuff like that. But I don't really know how to manipulate it, and I don't know that I'd be able to explain it to a patient as to why it's important. So how do we dumb that down and make it super simple?
Okay. The simplest thing that you can think about is, and look, I've taken PRI, I've taken every single system that you could possibly think of. And my major thing is, and I saw that you mentioned in the list that you gave me, the constraints thing. Like instead of thinking about, okay, lay on your back and breathe, and that's going to reset everything, I think more about, okay, what shape is this person's rib cage? And maybe the rib cage is easier to think about, right? So when I breathe in, the rib cage externally rotates. The ribs will start to flare. I mean, they flare for different reasons, but they start to open up. When I exhale, everything comes back towards the middle, right? And that's internal rotation. If I want to turn my rib cage to the right, basic PNF, to the right, basic PNF is I need to internally rotate the left, externally rotate the right. So my sternum now turns right.
Yeah.
So I'm thinking about, okay, I'm going to lay them on their side, put an ab mat on their side, put a towel. That's going to laterally, that's going to make the rib cage into a shape that I want to then start to open up space in the shoulder to allow for internal rotation to happen, right?
Yeah.
But to make it even simpler, if you stand with your feet hip width apart and you draw a box, so you draw a line across your toes, the outside of your feet, and then your heels. Everything inside that box is internal rotation. That's where force is produced, right? If you just think about it, if I have my feet hip width, and as I bring my feet closer together, that is internal rotation.
Mm-hmm.
That is adduction, right? Everything outside that box is external rotation. That is space I can move into, right? If, again, I am being pushed out of my box, then I need to compensate somehow to push me back into the middle. So, for example, if I'm pushing you towards the right, I'm pushing you outside the box, you need internal rotation. Well, you could look at somebody's wrist and you could start to say, okay, well, the radius is externally rotated. And I've done this where you get radial IR back and the hip IR comes back because everything on that side is externally rotating. So you could be like, okay, well, the glutes are going to be tight, lateral hamstrings, medial calf. They should have an inverted calcaneus, supinated foot, right?
Yep.
Like, okay, well, I can now think about, okay, I can IR, I can pronate the foot, I can tibial IR, I can femur IR, right? I can pelvis IR, rib cage IR, radial IR, all that stuff, right? All the way up and down the chain. So now you're thinking, okay, well, in order for internal rotation to happen, that is associated to gait, mid stance. So what are all the joint actions that have to happen to allow for mid stance to happen, right? And then from there, you're like, okay, well, this person has limited hip IR. They have limited hip flexion on top of that. At the shoulder, they have limited internal, let's call it, and external rotation, okay? The shoulder flexion, hip flexion, external rotation, they all go together, okay? Internal rotation, adduction, extension, they go together.
They go together from a standpoint. When you say they go together, like they're being neuromodulated to work in tandem to produce the forces we need? Okay.
Exactly. IR is going to put force into the ground that propels us forward.
Okay.
Gait is a repeated falling, right? It's
Mhm.
repeated controlled falling,
Yep.
right? And so when we land, this is us moving into a new space. That's external rotation, our heel strike.
Mhm.
Then my body starts to move over top of it. Then I start to pronate, go into mid stance. And a great book that talks about this is Human Locomotion. Thomas Mashad, he's awesome. I love all of his books. And then as you start to so ankle dorsiflexion, tibial IR, foot pronation, those are all happening together because your center of mass is going forward. Once I've maxed out on ankle flexion, I then have to lift up my heel. Now I get that Achilles, I get the windlass mechanism, I get all those things, right? All this is to say is that when I look at somebody's movement and I'm saying there's limited hip flexion in IR, right? I'm thinking that center of mass is very far forward over the toes. Because as I start to move towards my toes, I'm going to lose external rotation because I'm moving into, like, I'm basically moving into that external rotation space, right?
Yep.
So my pelvis is dumping forward. So how am I going to bring the pelvis back? Sure, you can work on a hip flexor, but again, you're not really addressing anything because as soon as you stand that person up, they're going to then shoot themselves forward. So how can I slow the tibia down from every time I hit the ground, it just wants to accelerate forward onto my toes. So I then look at, okay, hip flexion is limited, center of mass is forward.
And when
Internal,
let me interject for a
Yep.
heartbeat. When you say, "Hey, my hip flexion is limited," you're just looking at supine on the table?
supine on the table, right? So I'm
Active,
looking
passive?
passive.
Okay, I'm moving them up into hip flexion. It pinches or it stops. This
Yep.
person has limited hip flexion. In the past, like maybe old school theory, it would be like, okay, let's do a couch stretch and stretch your hip flexor. Let's do
Yeah.
some strengthening on end range hip flexion. Let's see if that increases your control specifically at the hip. You're taking a different approach. You're saying what? Don't let me put words in your mouth.
I'm saying that with you doing a couch stretch, you are driving more hip extension to a pelvis that doesn't have any. So
Yep.
again, if my theory is your weight is in your toes, your center of mass is towards your toes. If I give you a couch stretch and I'm extending your hip, does that not further accelerate that position? Does that make
Yeah, it's gonna
sense?
so once I put them upright, let's say we're increasing hip extension, that's gonna
Mhm.
allow them to fall forward more rapidly onto their toes, which is the genesis of the issue in your mind.
Yes. Right.
Okay, you're not just saying that to be
My
nice. That does make
No, no,
sense?
no. It
Okay.
makes sense. My idea is if they're going so fast in their toes, things on the backside are shoving them forward,
Mhm.
right? So now we're thinking about their mid back is compressed. Maybe they're squeezing their shoulder blade, or they got a winging scap, right? They got lower rib cage, like a flare. So the TL junction area, T8, T12, that area is just being squeezed. So they're flaring. And that is where they're extending their hip. So
Mhm.
they can't extend their hip, so they'll extend either their rib cage or their lumbar spine.
Yep.
Okay, so L4, L5 or T11, T12, because those are transitional zones. Those are areas where we hold our weight. Our T11, T12 holds the weight of the rib cage. L4, L5 is also going to help with that weight control. And
Mhm.
then our sit bones are another transitional area. They're very important. But that's why I cue tag of your pants, because that's going to allow the L4 to L5 to basically kind of, well, not L4, L5, but allow the pelvis to shift back and slightly tilt back versus using a ton of stomach muscles that are just going to round everything. And it's just, you're bending it instead of actually flexing it. Does that make
Mhm.
sense?
Yep.
Right? So, what I'm saying to you is you are stretching the thing that's trying to prevent you from falling over. It's like I am shoving you I stand behind you and I push you forward. How are you going to stop yourself from falling forward? you're going to push your hips back to try to catch yourself.
Yep.
You ever see somebody who, like, maybe it's just in the movies, but they run super fast. They try to stop themselves because they're about to fall off that cliff. Like, oh crap, there's a cliff there. And they kind of fold over, their hips shoot back. Like, that's essentially what I think about, is those hip flexors are stiff because they're reactionary to the center of mass being shoved forward.
Mm-hmm.
Right? So now I can't extend my hip because I'm already in extension.
Mm-hmm.
Right? Now, I obviously want to compare to the other side. So if I'm like, okay, right hip flexion is limited on the right, IR is limited on the right, well, how does it compare to the left side? If the left side is greater, then I have a pelvis that is turning that way. Just like I said with the PNF,
Mm-hmm.
turn towards external, away from internal. So why is internal rotation therefore limited? Because I'm already in internal rotation. I have limited hip flexion because I'm being pushed forward. I'm going into more hip flexion, right? So now I'm thinking to myself, I need to push off the left side, come back on the right. So let's say you want to do something manually, right? You now have to think about, how can I get my right back, my right PSIS, and my right heel heavy? And the opposite is true on the left side. So if you're doing something manual therapy wise, where you're like, I'm going to go after the tibia, I'm going to go after tibial internal rotation. Well, what you can do is position that person so that you put lined towels along the whole left side of their back. So passively, they're turning to the right. Do you see what I'm saying?
Yep.
And then you do your tibial IR mobilization while sitting on their foot. So now you also get the foot pronation to then be able to catch that rotation. I'm throwing back and forth between the left and the right. And so if I'm turning to the right, I need to be able to catch it. To be able to catch it, I need to be able to stay on the inside edge of that right foot. If I go on the outside edge, I'm then going to side bend. I'm going to hike my hip up. So I'm thinking to myself, I mean, you can also do it actively, where you're like, with the left foot, push it into the table, slightly turn it out, push yourself over to the right. You feel yourself heavy on the right, perfect. Stay there, and then you mobilize the tibia, or you do some kind of hip mob, right, to be able to acquire some more IR. So
okay, interesting. Now tell me how that translates. So again, patient supine, you look at hip flexion, you look at hip internal rotation, they're missing it. Those are some manual techniques you can do, and you're biasing them to put them in a more quote unquote functional position. So hopefully it kind of sticks with them, right? It gets hardwired into their movement patterns. You get them up on the turf. What do you do?
Thinking about similar strategies. So I can now go after, I can now think about, okay, if I want to turn them into the right side, I could do something like a front foot elevated split squat with the right foot forward and hold a dumbbell on the left arm. And the reason for that is, if I hold the dumbbell on the left side, I make the left side heavier. I make the left side heavier, I'm now pushing off more. If I put my front foot on something, I am naturally going to shift myself back towards my heel because I'm putting myself in a bit more hip flexion. So the more I go back towards my heel, the more hip flexion, external rotation I'm going to get. But now you say, okay, well, they're missing internal. What's going on? Well, if I hold the weight on my left arm, that's going to turn me towards the right. So now automatically I've got to push the inside edge of that foot.
And so in this example, right foot is forward, dumbbells and elevated.
Yeah.
Left hand's holding the dumbbell.
Yes.
Left rear foot is up on your toes because you're in that split squat. Okay.
Yep.
And then so as you come down and up, because the weight's on the left, it's shifting the force that needs to transpire on the right into like a flatter foot, a pronated foot.
Yes.
Okay. And what's transpiring at the hip because of that?
I'm going to get hip flexion and IR. So I think it's important that I clarify, there are two types of IR. There's hip flexion IR, and if you look at like something like the anterior glute med. It is a flexor and an internal rotator, right? At around 60-ish degrees of hip flexion, that is when those muscles start to kick on. Piriformis gains leverage as an internal rotator at around 80, 90 degrees. So we've got this hip flexion IR. So the way that I explain it is like, if you are doing a lateral lunge to the right, you have hip extension on the left, hip flexion on the right, but also IR on the right, so you don't just spill on the outside of the foot. So on the right side, we've got this hip flexion IR. This is like I am absorbing force. You're throwing a med ball to me and I'm catching it. I am doing a lateral bound and I'm landing on that right side. Conversely, the other end of the spectrum is more of this hip extension. So now, with the first example, with the right side, I'm landing, I'm going into the right hip, that hip flexion IR, my pelvis is turning in that direction. And so again, in order not to just spin out or orient or just completely dump to the right, I need that IR and adduction to keep myself to turn into that hip, right? Like I'm coiling into the right hip. If I want to now push off the right hip, I am now going to start to turn the pelvis towards the left. Right? So now I've got a pelvis that's moving over top of the femur versus what I had before, which is more of the femur turning. Right? So this is why I get people to do the supine hip flexion IR, and then also the side lying, you want to call it Ober's. I don't necessarily do the adduction so much, but just side lying and extending the hip. Because if I see a limitation in the side lying hip extension, but not the hip flexion, but not the supine IR, then I'm saying to myself, this person has a pelvis that is turned towards the right. They just can't get off the right side. So they can't push off. So now my exercises are more about, let's get them to do a cable lift on that right side to push them out, right? Let's get them to do a suitcase carry where they hold the kettlebell or dumbbell on the right side, because again, it's constantly pulling them to the right. So they've got to accelerate themselves towards the left, or they got to push
now
off.
when they're accelerating towards the left, in the example of coming out of the lateral lunge back to neutral, that's ER of the right hip as they come out of it.
Relative ER of the hip, yes.
Okay.
But
so
the pelvis
you're
is
go ahead.
technically IR'd. The pelvis is IR'd because it's so much easier just to see it. Like it's going like this. Right? So I have to basically push the pelvis to come forward. Right? Now the femur kind of gets left behind. So then there's this relative external rotation. And that's why I said this is more of a pelvis that's moving over top versus the femur moving. So another good example is when I'm doing a kickstand hinge or a kickstand deadlift. I don't want the femur to move. I don't want the knee to move. I want the pelvis to move over top of the femur. So this is going to promote more of that propulsive nature. The people who can't do a hinge are the people who don't have the femoral IR to hold that position. So if I go into ankle flexion and I keep my knee still, slightly bent, right? And then I try to fold over, well, that requires my femur to start in IR and then allow the pelvis to move over top. Do you know what I mean? Versus if I do a split squat with the right foot forward, well, the femur doesn't need to start in IR. It moves into IR as I am moving through the motion, right? As I'm descending into the motion. So
so that makes sense. I feel like when I give patients that split stance hinge movement, like when they can't allow the pelvis to rotate over, they'll compensate by throwing that glute out, or like they'll throw that hip out, right? So, and that's because they're not letting it, or they don't have the control to glide it over the fixed femur. So they steal from another plane of motion by moving laterally.
Yes. Or they don't have IR of the femur to be able to get in that position. So if you think of someone who's got like a squeezed glute, or sorry, their butt clenching. Okay. Yep. If you just squeeze your butt, the femurs turn out, right? Yep. They externally rotate. So with that, the femurs will follow the socket position. Okay. So if I squeeze my glutes, my pelvis opens up like a flower. I mean, again, pelvis doesn't move that much, but like just from a visual standpoint, the tension is going to create a moment where the acetabulum are going to turn a little bit into ER. Okay. Mm-hmm. So now the sockets are facing out. And so a friend of mine, he calls it a spatchcock chicken. Do you know what I mean by that?
I do. Yes, because of Thanksgiving. I did that with a duck.
Yes. Yeah. Exactly. There you go. So think of it like the legs are just going out towards the side. Okay. In order for you to put your foot in front of you, let's say in a split squat or in that kickstand hinge, you need the pelvis to IR and the socket to face more forward. That then allows the femur to have its relationship to IR properly. Mm-hmm. If you've got a socket out facing out towards the side, you've got to think that the whole pelvis, because the pelvis and the femur the acetabulum and the femur want to line up. The whole pelvis is now going to have to turn in order to be in line. And then what you can see is if that's your glute, see how it's on the outside?
Yep.
Right? So what I'll actually get people to do is I'll actually get them to, if their right foot is forward in this kickstand hinge, take their left foot and go out towards the side. So it almost looks like a lateral lungey position. And I say, what I want you to do is with this left, the balls of your left toes, I want you to shove yourself over to the right so that your sit bone and your heels lined up. Now hold this push as you go over, and it cleans it up right away.
Interesting.
But that's the mechanism that is happening, is that they cannot IR their hip or IR their pelvis to get everything stacked up. And so they are then just shooting out towards the side because they have to turn the whole pelvis so that the femur and the socket line up.
Okay, so super interesting. So like with this biomechanics approach, specifically with around hip IR, it sounds like it's so much body weight specifics or body weight interventions. Is there ever a place around this where you're really loading up the, let's say, glute or quad? You're doing things like back squats. You're doing heavier interventions, or is that like so far down the road?
No, 100%. It really depends on the person. So I personally, I'm not going to say never, but I personally don't give a back squat. I prefer a safety bar squat. Back squat puts the bar behind them, pushes them more forward. Most people don't have the ability to open up their back enough or have, call it external rotation, to be able to get in that position, so they got a flare. But I 100%, so I program for a lot of professional hockey players in the off season, and I load them up all the time, but we do creative things. So for example, I had this one guy, double hip impingement, cam on one side, pincer on the other. It's not great, right? Nope. And so whenever he went into hip flexion, obviously he got a pinch, right? When he got a pinch body weight to around 60 degrees. So I still know that he needs to be loaded, but we just constrained him a bit. So I got his heels elevated on ramps. And when I say heels elevated, I mean like full feet on ramps. That's going to push him towards his toes, so he now has to lean back. So that's going to open up some space in the back of the hip and the back naturally. I then got him to put a safety bar on his back. In his warm-up, we did some kind of asymmetrical squatting variation because he would get hip impingement with abduction on the right, but hip flexion, like fader, on the left, right? And so I'm like, okay, how can I get the pelvis to be able to push off that right side without him having to side bend and compress that outside area? So I did like a heels elevated squat where the right hand was holding the kettlebell right in between his legs. And so that was kind of a turn towards the left as he did the squat and didn't feel any issue. In fact, his abduction improved without as much pinching. So that was great. But what I did is I did a safety bar squat, heels elevated. I put it to a higher box. So I got him to squat only to about 70. And I put reverse bands. So I put bands on the top of the squat rack and then attached to the bar. And the intention with that is it decelerates him as he goes down. So you got to think like if he's getting pinching at 60 degrees, obviously there's structural changes that are changed in the hip, but that doesn't mean that we cannot open up his hips more and reduce tension and reduce pressure within the pelvis to probably be able to get more range, right? Like if his pelvis is dumped forward and his hip flexion is limited because the pelvis is dumped forward, if I can get that pelvis to come back a little bit, I could probably get some more range. Because as a hockey player, he doesn't need much more than 90. I mean, I would prefer 110 just to give him some threshold, just in case he gets in those positions. But anyway, with the reverse band idea, it causes him to unweight himself as he goes down. So he's able to reduce tension in the pelvic floor, in the pelvis. But then all the load comes back as he pushes off. So we're getting that force production, that IR, but we're constraining him in a way that he's able to accept force better. Do you know what I mean? So I 100% load, and I think that is a huge misconception for a lot of this kind of thinking, is that this is body weight. You don't actually train. I mean, I put a whole program, my Rebuild Blueprint, about how to train, strength train, in 3 progressive phases while applying these principles. So you're addressing compensations while also improving strength and fitness. Because I think people think it's corrective exercises, and it's absolutely not. You need to load these people, but understanding that hip flexion IR is in the same category as force absorption, or I call it acceptance. I feel like absorption basically tells people that it's like absorbing in one area. It's like acceptance or distributing force on a greater surface area. And there's force production, right? And so if I can do exercises like front foot elevated, split squat, well, that's my force absorption. My rear foot elevated split squat, that's my force production. My center of mass is more forward naturally, so I'm going to be producing force, hip extension, right? I get my high box squat, that's acceptance. I have my concentric focused or overcoming squat, right? So you just bucket these exercises in a more objective way, saying that force production equals center of mass forward. Force acceptance equals turning the pelvis back on that side, coming back, heels elevated, right? And so I can now
that makes a whole bunch of sense. Also, I think that is an awesome definition of the line between orthopedic physical therapists and sports physical therapists. Like your ability to train and bake in these correctives as opposed to segment them or silo them. Like, hey, here's your correctives, then we're going to train, but kind of pushing them together. That makes a great sports PT. I think that's a great highlight. I'm going to use the last few minutes of this conversation. It's really amazing because I sent you like a million questions and like I knew we would spend like the first 3 questions. So this is the important stuff.
I apologize. I talk a lot.
No, dude. Yeah, but it's great. And also I have to understand, like people don't tune in to hear my nasal voice. They come to hear the expert. So I appreciate you sharing. I just want to talk about shoulder because you have an awesome pod series around shoulder impingement, like some questions you were getting around the different types of impingement. I think impingement has become a dirty word because we used to talk about like this hook to acromion and how that was like the end all, and how it's actually the femur jamming to the acromion, and we've kind of gotten away from that. So give me like a 10,000-foot view of how you think about shoulder impingement, or let's call it anterior shoulder pain, and the way we approach those things.
Do you want me to talk about the 3 different types? Do you want me to talk about like how I see, like what I believe is actually happening?
Okay, let's start with the latter. What do you believe is actually happening, and then how do we fix it?
Okay, so going on what we first talked about of how position dictates function. So, and like the position of the joint is going to impact muscles, right? So a lot of people think that anterior shoulder pain, pec minor, pec major, sure, it's not going to hurt, but it's not going to address the issue when somebody's saying, hey, when I bench press or when I dumbbell press, it hurts. It's like, okay, well, you can remove tissue, but it's not tissue. It is joint position. So you're aware that, subacromial impingement, like if you look at the muscles, it's like deltoid overpowers rotator cuff. So then it jams the humerus into the socket. So we're not getting that approximation, right? Well, taking a step back, we are thinking about, okay, well, what does the shoulder need to be able to do? It needs to be able to flex, internally rotate, externally rotate, adduct, abduct. Well, I mentioned that flexion, abduction, external rotation, they all go together, right? And they are going to, in order to externally rotate my shoulder, for example, I need there to be space between my shoulder blades. If I squeeze my shoulder blades together, I can't externally rotate my shoulder because my shoulder blade can't move anymore. So I need that space to happen so then the shoulder blade can glide. So think of external rotation as living in between the shoulder blades in the thoracic spine. Whereas internal rotation has more to do with the distance between my sternum and my shoulder. Okay, so sternum and the humerus. As that space gets larger, I get more internal rotation, which is why people give pec stretches all the time, because the pec stretch is usually you go on a door and then you turn away from it, again, increasing that space. Not terrible in terms of an exercise prescription. In fact, I will give that in certain circumstances, but for different reasons, not because the muscle is stretching, right? So anyway, when I have an anterior shoulder impingement, I'm thinking about somebody's inability to flex the shoulder and internally rotate. No different than hip impingement. With the
same joint, like different ranges available to you.
Absolutely. It's the same thing that happens. So I'm thinking to myself, okay, what is the position of that shoulder? Is it retracted? Is it hiked up? Is it rounded forward? Okay, what is the rib cage flared, right? And then I'm comparing both sides. I'm like, okay, this side has less internal rotation, but if I take a look at the hip, okay, that matches. Both of them are 20 degrees, and that's it. Exaggerated. On the left side, it's much better. So then I'm thinking to myself again, well, if the left side is better, then that means the rib cage is turning towards the right. Do you know what I mean?
Yep. Because
if I internally rotate my left side, I externally rotate the right. So now the sternum and the humerus are coming towards each other. So that's why they say, okay, it's a tight pec. It's like, it's actually just a rib cage rotation. So then I'm thinking to myself, okay, I need to open up the space. I need to be able to push off this right side, drive IR. Right? So again, I haven't talked about muscles yet. I've talked about how the rib cage is turning, the position of the rib cage.
I mean, it's interesting because I feel like we're diagnosing the same thing. We're saying that you have trouble with increasing the space between sternum and shoulder, and that's because you have a tight pec. So let's stretch the pec. You're saying the same thing. You're just saying that's not the cause of it.
It's not the cause of it, and it's not going to be the solution of it either.
Right. Well, if it's not the cause, it's not going to be a solution. Right.
Sometimes, you do have to go after, like if it's been a long time where, if somebody's an older person, you're going to probably have to release a pec just to be able to get them in the position. So what I'll get people to do, and a lot of manual therapists to do, is I'll say, okay, here's the issue. We need to get them into a flexed and internally rotated position. What comes to mind? Side plank is a great example of that, right? You could even do like a rack carry. It's also a great thing to do. You could do a cable row, get them to hold the position, breathe in. You'll feel that chest expand because your elbows beside your rib cage, which when you breathe in, you're not going to be able to go out sideways, so you got to go frontwards.
Yeah.
It's just like a water balloon. You stick a water balloon, right, on the ground, it's going to go out. That's like breathing in. When I pick it up, it then goes narrow but wide. That's the IR part. So I give them the side plank position, and I'm like, okay, when they're doing the side plank, they cannot IR the radius, and their hand looks like it's turning out, or it looks like it's crunched up, or their medial wrist can't get into the ground, right? So they kind of arch, right? It just looks like a high arch of a foot. So I'm like, okay, well, they can't get into that position, so let's do the manual intervention of IRing the radius. Let's see what happens. Okay. That helped a little bit, but it didn't really overcome the fact that they're rounding that shoulder position. Okay, now maybe you go after some of the muscles around that area if you want to. I prefer to do different strategies, like let's lay them on the right side, laterally compress the rib cage so I can open up the front, and then start to make my way there. If all else fails, go after it manually first and then retry it. But you have to understand the exercise that you're going to pick based on the principles of why this is happening. I can't expand the front part of my rib cage. And I don't mean expansion like apical expansion or any of that. Like, I understand, like, like PRI and they're awesome, but like, I'm not going to just focus on those kind of positions. I'm thinking about what shape can I squish the rib cage to create space and put the shoulder in a better position versus saying, okay, I want the sternum and the shoulder to be further apart. I'm just going to squeeze my shoulder blades together. That doesn't actually do that. It just flares your ribs and leans everything back. So I'm trying to think about, okay, what's happening from this 10,000 foot view? Let me try a position. Okay, based on this position, which is where I want to get them, because this reflects putting force into the ground and making sure the shoulder, elbow, wrist, they're all able to produce force without rounding or arching. Okay, now I'm trying to reverse engineer what areas need to IR to allow that to happen. Okay, then you can go after manual interventions in order to overcome that, or you can try a different movement to try to do that. Maybe you're doing something like I really like pronated hand position, tricep extension. Because in this pronated position, you're not going to be able to fully extend the elbow very well if you do it right. And it drives IR from the hand. So I'm bent over, elbow reaching down. I get that traction, and then I extend the elbow. Great for people with golfer's elbow. Like golfer's elbow and anterior shoulder pain, they're together. They may not feel it, but it's the same idea.
What do you mean? What about C5? Ridic. I feel like everyone talks about C5 and the way it correlates to tennis elbow.
C5 does have a correlation, but you got to think about it like, okay, C5 is your upper back opening up, right? Yep. So if I have this rounded shoulder, okay, that's going to compress C5.
Yeah.
So if I turn my head towards we're talking about the right side, I turn my head towards the right, I then need to be able to open up the base of the neck on the right. That's going to allow for shoulder flexion to happen. So yes, you could do C5, but C5 is just going to help with what we're talking about. So you're not wrong to do that, but yeah, you could do that. But
listen, you could do it, but I think like one of the worries I have with my pea brain is getting too far away from the source of pain, injury, etc. And as soon as we get like, if there's so much to cover, at shoulder. Dude, I didn't even think about your ability to internally rotate or pronate at the elbow. What's transpiring at the wrist, like that to me makes a lot more sense than jumping all the way to the nervous system and going cervically. But that's just my pre-brain. There's so much to cover. You're right, like it would make sense, but like I like to focus it due to my lack of focus.
Yonda says that the biomechanics system is a reflection of the nervous system. So inherently, if you're impacting the biomechanics system or the joint position, you will be influencing the nervous system.
Yeah.
Again, people are like, nervous system, and yes, it is the main controller, but we have to go after the low-hanging fruit to impact the nervous system. You want to impact the nervous system, breathe a little bit. Yep. Right? Like it's a major thing. You want to impact the nervous system, give the joint variability.
Yep.
Pain and injury happen because the joint's not able to express certain emotions. And I appreciate there's a biopsychosocial model, of course, but we are movement professionals. We focus on the movement aspect of things. Of course, you can speak to somebody. Like I wouldn't be like, oh, damn, that's pretty bad shoulder. Or,
yep.
Or when they say, yeah, it doesn't like it, you change their narrative. It's like, no, it's your right shoulder. It's not it. You know what I'll get people to do is every time I work with them, if they have pain, like with their shoulder, I'll get them to high five me at the end of the session with that shoulder to show that shoulder can do something, right? So there you go. Neurologically, I've changed their input into that area, right?
Yeah.
But I just want you to think that like shoulder IR, hip IR are very similar. The difference is that with the hip, the foot's on the ground, the knee is also connected to it. So if I want to improve IR of the hip, I have to connect it with the foot. Your hand is your foot, your elbow is your knee. It's the same thing. So you have to, I just like the side plank as even an assessment because it tells me where things are breaking down.
Yeah.
Right.
Yeah. That's
your C5 thing. I actually think it's, so the three types of shoulder impingement, like you get your Hawkins Kennedy, which is that flexion, IR, adduction, right? That's what we're talking about right now. There's your end range shoulder flexion impingement. That's your C5 thing, because in order to get the end range shoulder, you need to be able to turn your neck to that direction. The base of your neck needs to be able to expand. That scapula has to posteriorly tilt. And then there's your subacromial impingement that you talked about, which is more abduction, right? That's going to be more a focus of your mid-back. So think of Hawkins Kennedy, sternum and humerus need to move away from each other. Flexion, IR. End range shoulder flexion, that is now base of the neck, right? And then your subacromial abduction, that has to do with in between the shoulder blades. So your scap decompressions are awesome in this situation. Your low reaching positions, your cable pulling your shoulder blades apart. So for example, I've got somebody with subacromial impingement, and I'm getting them to do a squat, for example. It's low cable, heels elevated to a box, let the shoulder blades be pulled apart by the cables. You're gonna get it, right?
Yeah, that makes a lot of sense. I think that is something we so inherently miss as a profession. Like we are obsessed. Shoulder pain, scap retraction.
Yes.
And I
YTW.
YTW, Jesus, or what's the name of the throwers 10 who created those? Blackburn. Like
yes.
That stuff, and that's too narrow of an outlook. Like you have to understand that there are differences in shoulder impingement and there are different ways to attack those. I think scap protraction is totally forgotten about or not understood, and I think it's a really important piece, especially with throwers.
Yes, and what I will say is that I am not somebody who comes here and tries to look at what, like, I'm not saying this exercise is bad, this exercise, like I try to find where the exercise is going to be helpful. So for example, your YTW, it's actually not bad for that anterior shoulder pain, because what are we trying to do? Like I am trying to open up that anterior part of the chest. Well, if I shove you from the back, so I shove your scapula against the spine, which is upward rotation, the medial board of the scap pushes against the spine and goes up. That's where IR lives, right? 60 degrees. In that area, like I want the scapula to push against the rib cage to open up the chest. So your YTWs are actually not bad for that. You just got to make sure that when they're doing it, they're not flaring their rib cage at the same time because they're not actually going to get that movement, right? Yeah. Your face pulls, also awesome for that. But when it's not great, those things are not great for subacromial impingement or for that end range shoulder flexion that I was talking about.
Yeah.
That's your protraction stuff you need, right? Or like, do you know how many times that I've used a bicep curl to help somebody with end range shoulder impingement and it's worked by just getting them to look down at their bicep and then doing a bicep curl in like a preacher position? Because I get the cervical rotation, the elbows in front, which then opens up my back. And then by curling, that's going to posterior tilt the scap, right? Holding there and breathing in. So, and then obviously the supination of the wrist, which is going to translate up. So yeah, like you get super creative and it becomes fun, but then guess what? Your training looks the exact same as your rehab interventions. And that's what people want. They don't want to feel like they're doing rehab. They want to feel like they're moving and doing stuff. And don't get me wrong, you got to get them on the ground and be able to create this context. And that's the way that I explain it. Like, I can't expect you to do this in a squat if you don't know how to do it on the ground and be able to feel the different areas I want you to feel, right? And then I get them up. And like my warm-up, even if I program for somebody who is not injured, not in pain, although those are the people that I usually do work with, it's like neurodevelopmentally. So it's like they're on their back, they're on their side to some capacity, they're quadruped some capacity, kneeling and then standing, right?
Yeah. You do a great job of that on your pod, talking about knee pain and ways to start all the way from the like laying supine or laying sideline and then getting them all the way up to doing work actually loaded and upright. Powerful stuff. Alex, I could talk to you forever, and I knew this would be the case. It's awesome. Just in closing, do me a favor, tell everyone where they can find you, because your stuff has been so instrumental in the way I look at rehabbing athletes.
Well, I appreciate that, man. Yeah, I'm most active on Instagram at alex.effer. I have my YouTube channel that I've started over the last year or so. That's at Resilient Rehab. My podcast is the same thing, at Resilient Rehab. And then you can find all my programs and my courses on my website, resilientrehab.com. Honestly, like all the stuff we're talking about is really like an amalgamation of all those different courses. Like I've got my Evolved Biomechanics mentorship, which really talks about assessment, talks about how to think. I just released my roadmap, which is more about how to think about exercise and breaking down each individual exercise based on this kind of thought process, right? And then Foundations was for the questions that I would get from Evolve. I created that, which honestly, in retrospect, I should have created Foundations first before Evolve. But the Foundations was really just for people who, the common questions in Evolve. So you want to check out my courses, all on my website. It's in my bio too for Instagram. But yeah, those are the main places you can find me.
Awesome. I've learned a ton. You did a great job of talking high level and then whittling it down to getting very specific. I really appreciate your outlook. I know we'll get great feedback on this. As always, everyone listening, let us know what you loved. Let us know what you hated. True Sports PT on Instagram. If you love this conversation like I did, share it. Spread the freaking word. Alex is a wealth of knowledge and really inspiration, hitting on so many different topics to be a great sports PT. I've learned a ton. Thank you so much for listening. Bye-bye. Bye-bye.